Without further ado, let's introduce them to our stage here today. So please give a warm welcome, firstly, to Professor Cleona Kerwin. Cleona is a clinical scientist in surgical oncology, a consultant oncoplastic breast surgeon, and she also heads up Prevent Breast Cancer Scientific Advisory Board. So welcome, Cleona.
Thank you.
I'm loving a unicorn dress as well, absolutely. Next up, we have Professor Tony Howell. Please give him a warm welcome. Tony is the Professor of Cancer Prevention and Medical Oncology, but he also goes by the name of Captain Prevention. You've not got your cape here today, though, have you? No. Next up, we have somebody who is also another Howell. Yes, this is Tony's son, and he is the doctor, Dr. Sasha Howell. Give him a round of applause. He's a senior lecturer in breast medical oncology at the University of Manchester, and Sasha is also an honorary consultant in medical oncology at the Christie and the Nightingale Centre. And finally, please welcome to the stage Dr. Michelle Harvey. Michelle is an award-winning research dietitian. She is also author of the best-selling book, The 2-Day Diet, and that has been published in over 18 countries and has raised over £300,000 for Prevent Breast Cancer, which is absolutely brilliant. I don't know about you, but I feel like I should curtsy or something. Thank you so much for joining us. Well, firstly, I'm going to start with you, Cleona. Should I call you Professor? I don't know what to do.
Cleona, please.
Now, I'm going to really kind of embarrass you now, because I do want to just say that she's one of only 2 women in the UK who are professors and breast surgeons. The Spice Girls have nothing on Cleona. And you've got better shoes. Just explain to us, I think, first and foremost, what are the main risk factors out there at the moment?
I think we have to be realistic. The most obvious and major risk factor is simply being female, because breast cancer is common. Then the next risk factor is ageing. The risk of breast cancer increases as you get older. Other risk factors include exposure to female hormones, so maybe having an earlier age of starting your periods, a later menopause, taking HRT, and then there are lifestyle factors such as obesity and exercise, and that's, you know, the key to Michelle's work. There's also very important risk factors are having a family history of breast cancer, which is what the Howells are specialists in looking at. And then I think one of the other risk factors that we talk a lot about is breast density, which is a risk factor that you recognise when you have a mammogram and you see that someone has a denser breast, and that's a particular area of research for Prevent as well.
Well, that is something that I hear a lot. It is bandied about, breast density, but for myself, it's kind of, what really is that? Because, you know, I don't know if you out there know what that is, but I would think it was larger breasts, breast densities, you know, but it isn't, is it, clearly?
No, it isn't. It's all about what your breasts look like on a mammogram.
Right.
So a mammogram is an X-ray of breast tissue. And you know when you have an X-ray of, I don't know, your arm, you can see the dense white bone, and then the muscles around it are less dense and they look black on an X-ray. So the same is true of a breast X-ray, that there's white areas and there's dark areas, and the dark areas tend to be more fatty tissue and the white areas tend to be more of the glandular tissue. The glandular tissue is the stuff that makes the milk, and also surrounding, supporting structures like collagen. And ladies who have dense breasts, their mammograms simply look whiter, and ladies who have low density breasts, their mammograms look darker.
Right. Oh, thank you. Well, we are going to come back to you in a bit, Cleona, so please stay there. But we have got a gentleman who hasn't been able to be with us today, a gentleman called Gareth Evans. Now, he is leading the way, as this panel of experts are as well. But we've got the next best thing. He might not be with us today, but he has been kind enough to film a lovely video message for us. So let's hear what Gareth has to say on our screens just up there.
Hi, I'm Professor Gareth Evans. I'm a Professor of Medical Genetics and Cancer Epidemiology at Manchester University, and I also work at Manchester Foundation Trust, where the Prevent Breast Cancer Centre resides. And I've been working with the Prevent charity really since its inception a number of years ago. And my main focus at the moment is trying to better identify the risk of breast cancer in women so that we can more accurately target preventive measures such as diet and lifestyle, but also preventive therapy such as tamoxifen and anostrozole to those who are at the most risk so that we can do the most for them, and also to be able to reassure those who are actually at low risk. And this has major implications for screening in the UK. Currently, screening is a one-size-fits-all. Everyone gets the same 3-yearly screening from the age of 50 to 70. What I would hope we will do, and many people are focused on, is the idea that we can do what we call risk-stratified screening. And that is using information from the genetics, using information from the density of the breast tissue on the mammogram, and standard risk factors. And pulling those factors together, we can really very accurately stratify women's risks, let them know what those risks are, and then adapt screening and preventive measures to the individual. So unfortunately, I can't be there today. I'm going to have to hand over to my great colleague, Tony Howell, who's going to talk now.
No pressure, Tony. But following on from Gareth, can you just expand a little more?
Well, I thought Gareth was very... Am I okay? I thought Gareth was very clear. It was a very nice introduction to what we're doing. We've been working together since 1990, and he is... my wife's in the audience, and Gareth was our best man. So it's a family, it's a family occasion, virtually. So the important thing that Gareth was explaining was predicting risk. There are some women who are at high risk of breast cancer and some women who are virtually no risk of breast cancer. So there are two ways that we would then use this risk when we estimate it. One is, as Gareth said, to change the screening program, and I'll just tell you a bit about that in a minute. The second is we have, as you probably all know, a family history clinic at the Nightingale Centre, the Prevention Clinic. And while I'm thinking about it, I think we are indebted for our research to prevent breast cancer. It's terribly, terribly important. But to go back to screening, what we have done is a very large study in Greater Manchester with 60,000 women who agreed to fill in a form about their own risk factors, to have their breast density estimated, and also to have a DNA test. And Gareth didn't say much about DNA tests, but there are tests which are not gene mutations, but they're slight alterations in DNA. And if you've got one lot, you're at high risk, and you've got another lot, you're at low risk. So in the screening program, we can tell women that they are at high or moderately high risk, and we can also tell women, in the study we did this, that you're virtually at no risk. And so what we want to do is to say, the ones at low risk, either if they wish, stop screening or don't start, or only have one at 5 years or 10 years. Whereas those at high risk, we suggest that they have annual screening all the way through, or if not that high, 2-yearly screening. But there's one other thing that is important in this, because we know the breast density of all those women. And if they're at high breast density, not only does that increase risk, but it makes it a bit harder to see the cancer in the breast, because cancers are white and density is white. And so we are just starting a trial to say, is risk-adapted screening based on risk, but also based on density, density-adapted screening, feasible for women? And the trial has started. It's called MyPEBS, which is my personalized breast screening, where half the women will have standard screening and the other half will have screening based on risk, so that those at highest risk may get an MRI scan. Those at high risk and density will get additional ultrasound and mammography. So you can see what we're trying to do. And this approach has come out of the work that has been done here in Manchester. So we're really quite proud of that. That's one thing.
Yeah.
Can I go on?
Of course you can, yeah.
The second thing is that women come to our family history clinic and say, well, look, I've got a family history. I want to know my risks and I want to know what to do about it. So we've applied the same risk factors to them. And actually, when we put it all, the more risk factors you put in, density, DNA, standard risk factor, the more you put in, the more accurate the test is, and the more accurate the risk you give to the woman. So many women can just be reassured. You say, well, you don't need to have any follow-up. Others will need more follow-up and may need preventive therapy, and Michelle will tell you something about that. The preventive therapy we use is a drug called, many of you will know, tamoxifen, but another drug called anastrozole, both of which we have been highly instrumental in developing. Anastrozole, I was the chief investigator of the trial, which showed that it reduced breast cancer by 50%, and NICE, you know NICE, have passed it, and they were very happy about it. Sasha was on the NICE committee that passed it, because it is risk reducing for money, I guess, because if you use anastrozole, you save money for the health service, because people like Cleona are not needed, and of course Cleona is very expensive. So I hope that sort of outlines what we do.
That's brilliant. Thank you so much, Tony. And it kind of leads me into what, Sasha, you're doing, because your dad, family resemblance there, we talked about the family history clinic and about how that comes into play with risk factors. But only 20% of women who develop breast cancer have got a family history. There's a whole other 80%, isn't there? And I know you're working closely in that and doing research with that, and younger women in particular.
Yeah, absolutely. So, as you say, about 80% of women don't have a family history who then go on to develop the disease. And also, around about a fifth of women who develop breast cancer do so before what is standard screening age. So, what I'm doing is standing on the shoulders of giants, like this gentleman to my right, and Gareth, and trying to develop a mechanism by which we can identify women at increase of risk when they're young. And so trying to do the simple risk factors using a simple app. You type in the age of the period started, whether or not there's been an early pregnancy, but then that would trigger the sending out to women in the community of a saliva sample tube. They would fill that, we would get the genetics from that, and then we're developing a low-dose mammogram, which would be read by artificial intelligence as opposed to being read by a radiologist. And when we put all of those three things together, just like for the women that have been in the PROCAST study, We would then be able to say, we think you are at standard risk. That doesn't mean you don't be breast aware and continue to look out for signs of breast cancer at all. It doesn't mean that you don't try and approach life in a very healthy way. But for those women at a high risk, we would then bring them into what we would now call our family history risk and prevention clinic. So it's not just all about the family history. And then we can offer preventive therapies. And one of the things that Prevent have been funding me to do in the lab is to actually try and identify novel ways to grow breast tissue so that we can then look for new ways to prevent breast cancer. So Professor Howell has just, sorry, Dad, has just spoken about tamoxifen and anastrozole. And these are great drugs at preventing a certain type of breast cancer, the commonest, which is hormone receptor positive breast cancer. But at the moment, we don't have any medications that we can use to prevent estrogen receptor negative breast cancers. And that's something that we're working on. And with Prevent's help, working on ways to grow the breast tissue in the lab, we can then test out new drugs and then translate that into these young women to try and prevent them from getting breast cancer in the future.
Wow. So this is really the start of the journey, isn't it, for you?
Very much. This is early days in this research. We have just completed another clinical trial of an anti-progestin, which looks extremely encouraging at switching off the breast and therefore potentially preventing it. And we will take that clinical trial forward now into its second phase. But in terms of the risk prediction work, yep, we're just getting going, but it is all going, so that's great.
Fantastic news. Now, you talked about kind of the prediction. We've heard a little bit about that. We're now going to move on to preventative measures and things we can do. And I know that's your area, isn't it, Michelle? And you've been working kind of in the lifestyle and how that's affecting cancer. Tell us a little bit more about that.
So probably everybody in this room's heard before. So we know that breast cancer risk is linked to certain lifestyle factors. We think probably about 1/3 of breast cancers that occur in this country are very strongly linked to potentially changeable lifestyle factors, which are what we weigh as an adult, how much weight we gain, which is really important, and whether we're physically active, whether we do exercise, and how much alcohol we drink. And importantly, you've obviously heard a lot about how we're focusing on people who have a high sort of background, genetic risk or a high breast density. We know that lifestyle factors will impact on people's risk, whatever that background risk is. So our focus is trying to really help the women who have a high risk of breast cancer anyway, and how we can help make that, you know, reduce by doing the right lifestyle factors. So, you know, we know that the average woman in this country gains about 2 stone as she goes between the ages of 20 and 50, and that increases risk by about 70%.
Wow.
And if you gain about 3 stone, which is not unusual, that can double your risk. So they are quite big risk factors that we're really trying to tackle.
How do we get women to introduce these lifestyle changes into their lives, really?
So it's not easy. So you've heard, as I came up on the stage, that we've developed the 2-day diet, and this is trying to make it easier for people to reduce their calorie intake and control their weight. So that's been a great sort of boost. We know that we can give people information. This fantastic BooBee campaign is giving everybody information about the lifestyle risk factors that they can change. And that's great, and that's really important. But we also know that probably only about 10% of the people that read those messages will actually change their behaviours on the basis of, you know, changing how we live our lives, what we eat, how physically active is challenging, because there's, you know, life is busy, all our patterns are wrong, and it takes quite a lot of work to change behaviours. So we've developed, with the help of Prevent, some very low-cost, remotely delivered support programs to actually help people change their behaviours. So they're in these programs for about a year, and we know that not everybody that comes in the program will successfully change their diet and physical activity and lose weight, but about 6 out of 10 will. And if you know, we've tested it probably to date in about 300 women in Manchester, and that's very effective. So to put it into context, if you go to something like Weight Watch, you're getting about 15% of people being successful. So we got that 6 out of 10, and if we could roll that out to a wider population across Manchester, across the UK, you could potentially reduce breast cancer by about 20%. And of course, it's not only breast cancer. If you're getting your lifestyle factors right, there's about 12 other cancers that will be reduced in risk. You'll be reducing your risk of heart disease and stroke by about 40%, diabetes by 50%, and actually dementia by about 30%. So, you know, we have a program that is potentially quite cheap and easy for people to do, and that's really what we want to progress, is rolling that out.
It's incredible what you've just said there and what the results that you can do and how it can make a difference. I know that you've worked with our team today, haven't you, on the afternoon bee and the lovely afternoon tea that some of us will be enjoying later. You've had a bit of a hand in, haven't you, Michelle?
I have, and I can't remember what on earth we're having.
I thought you were going to give us an insight.
I'm sure it's great, yes, yeah.
But it's kind of all with that in mind, isn't it? So it's going to be quite healthy.
I mean, there is a 90% rule with, you know, with any, when we talk to anybody about lifestyle, we do not expect people to eat healthily and be healthy 100% of the time, but it's kind of paying attention maybe 80% of the time. So whether this is one of your days off, then you can decide.
We'll have a day off today. Fantastic. Now, I suppose it's really asking you all a question that is possibly on my lips and the people in this audience lips, that if we could wave a magic wand, which I'm sure we all really want to do, what do you think would help in the fight against breast cancer going forward? Or have you got any, I suppose, take-home words for the people sitting in this audience? Cleona, I'm going to put you on the spot first.
I suppose until we have the holy grail of prevention, so until we get rid of breast cancer, then I think my key message is that we must be breast aware, because the earlier you diagnose breast cancer, the better the outcomes and the less treatment you're going to need. So know your own breasts, examine your own breasts. If you see a problem, act on it. Nag your sisters, nag your friends, nag your mothers, nag your daughters, make sure they're breast aware. And when that letter comes through the letterbox inviting you to go to breast screening, accept it and go.
That's powerful and great words there. Thank you, Cleona. Captain Prevention, what would you like to say on this matter? Come on, Tony. It's incognito.
Well, I think two things. One is that I'm very excited about the trial that we're just starting, the MyPEBS trial, My Personal Breast Screening. That's being performed across Europe. We've got a European grant of £12 million to do that, and additional funding from Prevent Breast Cancer to do this trial across Europe. And we should get the answer. You usually think it's going to be way ahead, but we should get some answer from that trial in about 4 or 5 years. And that will give a signal as to whether we will introduce that into the whole of the screening program. Because my other message is that we know a lot of stuff already, which we could translate for the benefit of women, but this translation process sometimes takes a bit of time. For example, I mentioned in the family history clinic, we can now more precisely perform risk, but to do that, and all women who come, we have to do a DNA test. Now, we need the NHS to support that, but we need to give them evidence that it is worth supporting. But that then translated across the country could make a really big difference to the reduction in risk of breast cancer. Now, let's not get miserable about the whole thing. Breast cancer deaths since that screening program started in 1988, and deaths from breast cancer have halved in that time. And screening cuts breast cancer deaths by 20%. Now, we want that to increase, and we want to reduce deaths by early diagnosis, and also by getting what we already know out there across the country, because that would have a benefit. So people say, oh, it's going to take years to do that, but in fact we have the tools now to be able to do that. It's a matter now of getting it out there, and I spend quite a bit of time trying to do that, because it's very important for women.
Thank you very much. Follow that, Sasha.
It'll be shorter.
Okay.
Magic wand is, for me, a detailed understanding of what it actually is that is going to cause that lethal breast cancer. Because if we understand that, then we can prevent it. Then we can develop drugs to reverse that process and stop it happening in the first place. So that's my magic wand.
You've encapsulated what Tony said in a couple of seconds there. And lastly, Michelle.
Okay, so am I allowed 2 quick ones?
I think so. We'll allow, won't we?
So just following on from what Tony says, so we want to get prevention out there for women, first and foremost in Manchester, but then across, you know, the UK and globally. So we, you know, in terms of lifestyle, we know that we know a lot of people are not attending to the risk factors that will reduce their risk, and we know we have a way of helping people do it, and that's what we want to do, is to try and roll it out, integrate it into the breast screening service. So when you go for a mammogram, not only do you get the mammogram, but you get an opportunity to help you change your lifestyle behaviours for the better. Not just a leaflet telling you that you're at higher risk, but actually something that will help you get on the way. And there are roadblocks in trying to get that out. We know we need to do a lot of work in winning hearts and minds across the NHS. Obviously, we all know the NHS is really just trying to keep going. So trying to get them to adopt a new service is quite a challenge. So, you know, we'd love to. We've tested it out, as I say, in about 300 or 400. We'd love to roll it out in Manchester. So we need to do some work with hearts and minds of, you know, public health in Manchester, and also, you know, some funds to really get that moving. And then the other thing that some of our work is leading to is we really need a good marker of, you know, if somebody does follow a prevention lifestyle, are they actually reducing their risk? You know, like you have cholesterol for heart disease and stroke. So when you go away and you change your diet and you start exercising, you know, you'll get some really nice feedback that your risk of heart disease and stroke is going down because your blood pressure is coming down, your cholesterol is going down. And that's what we need for breast cancer. And some of the work that we're doing with when people follow lifestyle, we're looking at things in the lab and with density. We really need a good marker that, you know, if someone's putting a lot of effort into lifestyle, that they're actually getting something back from it. So that's what we need.
Fabulous. So I'm sure you'll agree, some great words there from our panel. If you'd like to give them a round of applause. Thank you so much. So hopefully that has given you a little snapshot, really, of where we're at. And, you know, we are in these amazing safe pairs of hands here with this panel, and they're doing some amazing work together with Prevent Breast Cancer. And that is what we are here for today and celebrating. You've got a fantastic afternoon ahead of you. There's going to be some entertainment, there's going to be some singing, there's going to be some drama, and most of all, there's 100 inspirational ladies who have got a great message that they will be spreading. So please have a lovely afternoon. Thank you for being an amazing audience. Now go and enjoy Afternoon B.